so I guess I have to talk into both microphones here. So, Mary, I'm curious a little bit about sample preparation for these assays. Since the formalin-fixed tissue and the process of extracting the DNA is not typical as what you would do with blood or something else, are there special considerations that you might want to use in preparing the DNA?
For those of, how many of y'all actually, I need both. Do any of y'all actually do DNA extraction back in your labs? Well, not you, don't count. So it's not hard. I mean, paraffin is harder than blood, but sometimes it's easier than blood because we can target what we're looking for. So in our hands, there are kits available that are optimized for paraffin embedded extraction. Basically, most of these tumors have greater than 40 to 50% tumor volume if the pathologist chooses correctly. So really getting target tissue out is not a problem. One thing about the Infinity is that it's very sensitive. It's a lot more sensitive than some of these other techniques you read about as far as looking for these mutations. If you can get quality DNA out of your tissue block, then you can actually have successful results on the platform. It's not rocket science by any means. I have students that do it, everything, and they all turn out well. So as long as you follow proper lab protocol and do the analysis, there really isn't a lot. The other issue I just want to mention that comes up is whether you do macro or micro dissection. Again, most of these tumors have abundant carcinoma in them, most of these tissues. So doing micro dissection is not as much an issue. Macro dissection, yes, but I'm talking macro dissection in the sense of you can actually take a scalpel and cut it off of this tissue slide that they give you. So it's not, again, no laser captures needed for most of the cases.
Thanks, Mary. So it seems to me that it seems like a lot of times you might look at a different type of tissue sample and think that it's difficult to work with, but I think what Mary said is that it's not that difficult. It actually has its own advantages where you can be a little more selective in what you're taking. You can enrich for the cancer cells basically and have a better chance of picking up the mutations. So one other aspect of these types of assays has to deal with the amount of material that you actually have to work with. And I'm wondering if, Carla, maybe you could make a comment as to the advantages of, say, multiplexing on that type of sample.
Well, theoretically, you have almost unlimited because they can go back to the block. But in practicality, that's not always the case. So we ask for 3 slides that are enriched. And we use 2 and save the other one in case we drop everything else on the floor. But you can do it on 1 slide and get all of these assays out with 1 cells, not even the whole slide, but a portion of the slide, all of these assays out. So you're not going back to a limited sample that's being stored. The other advantage to these kinds of assays is that the correlation between metastasis and primary tumor is 100%, at least in the literature. So if you get a metastasis to the liver and you get the liver metastasis because the colon cancer is long gone, or whatever, they don't have it, you can do it off the metastasis. So we've done it off of lung metastases and liver metastases from colon cancer. So there's a lot of flexibility in doing a multiplex with just 2 slides, which is easy to get.
Before I hand this back, I'm going to say one other thing which she mentioned in her talk about doing this up front versus in the metastatic setting. Frequently, blocks get lost, blocks get moved. So there is a movement by both molecular pathology labs and oncologists to just genotype the person up front. So whether they go to hospital A or hospital B, at some point in the course of their disease early on, they have been genotyped because, as Dr. Madison mentioned, it doesn't change really. And then if you had a tumor in the lung and you were worried about whether it was metastasis or unknown primary, and you knew there was a KRAS mutation in the colorectal, it would be easy to go back and correlate that.
All right, thank you. At this moment, are there any questions from the audience? Okay, I'd like to thank you for joining us today, and enjoy the show.